The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. This is Desiree Castillo with Centralized Training at UT Health San Antonio. We're happy that you could join the ANSA and CANS Technical Assistance webinar. I do hope you are all safe and in good health during these unprecedented times, and so we're glad to have you join. Today from HHSC, Mary Webb-Tafoya is on the webinar, and we are both excited to have Dr. John Lyons and Dr. April Fernando, who will be discussing conducting the ANSA or CANS by phone or video conference. Before we get started, just a few housekeeping reminders. Everyone is muted, so the only way to communicate is through the questions box on your control panel. We do encourage all the questions you might have, so feel free to use that at any time during the webinar to enter in your question. Just know that all questions will be reviewed at the end of the webinar. Also, please use either your speakers on your computer or your telephone just to prevent any echo or feedback. The slides for today's webinar are available under your handout section of the control panel. And as always, the webinar is being recorded, so both the link as well as the slides will be sent out to all attendees later this afternoon. Please now help me welcome Dr. John Lyons and Dr. April Fernando.
Great, thank you.
Hello.
Desiree. Hello, how are you all? So thank you. Let me echo Desiree's thank you for all of you for attending, and also like to say thank you for staying at home and saving lives, because that's a really important phase. I think if you look at the data, we're entering what appears to be a national nightmare, and the best thing we can do for each other is to stay physically apart but emotionally connected. And so thank you for doing that, and thank you for your service to others. We have moved, I think, since last time I talked to this whole group, so we're now at the University of Kentucky. Our group moved over there starting in, I actually moved in September of last year, but the rest of the team came in January of this year. We're quite excited about that because the university has a lot of resources that they're using to support the expansion of our work with TCOM and the ANSA and the CANS and so forth. For those of you who don't know Lexington, where we're based, it's kind of like Austin, Texas, without all the tattoos. I mean, so it's a college town in the middle of a big state. For those of you who love Austin, you'd love Lexington. For those of you who don't, you could stay in Paducah or someplace else in the state, and it's a lot like the rest of Texas. Okay, so these are fairly. Can I have the first slide, April?
Yeah, before you start, can I just say one thing?
Sure, absolutely.
Sure. I just want to throw in just a little disclaimer. So while we're going to be talking about the use of phone or video conferencing and completing and utilizing the ANSA and the CANS, we are obviously going to be addressing some issues that are pertinent to the delivery of care via telehealth. But in no way is this a presentation on all you need to know about how to provide services via telehealth. So for more information on that, please check with your licensing boards and the professional ethical guidelines of your discipline. All right, here you go, John.
Thank you. That's an important disclaimer. All right, so the next slide. So you know, we start out calling it social distancing, but it's really physical distancing, and that's the reality of the new environment for at least the next few weeks. And if you look at the data, you'd be thinking it's more likely for the next 2 or 3 months, and it may even be for the next 12 or 18 months. And in some ways, you know, depending on the success of this massive social experiment, it may be something that becomes a more constant part of our work life. So this is our reality. Staying at home is staying safe. That's how you save lives, and that's just how things are. So I can have the next slide. That, of course, has changed how we interact with each other in some interesting ways, not as much as it would have back in like the time of the Spanish flu, where they also had a lot of quarantine and separation and physical distancing as well, because we do have technological solutions that we didn't have before. And all of you who have relatives who live somewhere distant from you or friends who are distant from you are probably already used that technology in your personal lives, whether that be Facebook or Instagram, or I FaceTime with my wife all the time because we're forced separated because of the virus. So those things exist. They've now, that makes it a completely different reality, a world for us, and that provides us with some opportunities. And one of those opportunities is the brave new world that you are moving into of providing ongoing care to people with behavioral health challenges in a way that hasn't been traditionally done. So I've been talking to a lot of people who are doing this, and in some ways there's some advantages, and in some ways there's some disadvantages, and a little bit of it depends on the person. So there's, depending on the type of needs a person has, they will either find this better than in person, but some of them might find it worse. So that's just the reality of it. So if I could have the next slide, April. So the key in terms of, and I'm just going to talk a little bit, and I'm going to turn it over to April because April's is the licensed clinician in our group. So the most important thing, I think, to understand how to do the ANSA and the CANS in this telehealth type environment is to remember what it's intended to be. And although we've been at this for a while in Texas, I think some people understand what it's intended to be, and I think there's still pockets of folks that don't really understand what it's intended to be. So the ANSA and the CANS are storytelling approaches, right? They are intended to be the output, the way of recording information from a conversation. They're not intended to be an interview format. They're not intended to be a measurement device that tells you how to get information. They're much more like a closet organizer. Once you get that information, how do you organize that information to help you moving forward? So the idea behind the approach is that anytime you're going to meet with somebody to help them, you want to hear their story. The best way to hear somebody's story is just to let them talk. And you listen to their story, and sometimes, and this is particularly true if you work with children, but it can also be true if you work in more forensic type of environments, sometimes, or complex environments, some in family environments. I mean, I don't know, for those of you who have kids, I suspect you had the same experience I had, which was, you know, my kids' story of their school was always a little bit different than the school story of my kids, right? So you have these multiple storytellers, and your job as a helper is to pull those multiple stories together to come up with a single story. Now, every story is different, but if every story were different, there'd be nothing we could do to help, right? Because we don't help people based on how they're different. We help people based on how they're the same. So as you're listening to people's stories, you're listening for common themes of those stories. And so the ANSA and the CANS, actually the items of them represent the common themes of people's stories. So the way you could do this, if you're doing a sophisticated application of this approach, is you're having conversations with people. You might have corollary information about those people's stories. You know, there's multiple storytellers, maybe a records from previous treatment. It may be a doctor's report. It may be a psychological test. You have multiple storytellers. Your job is to hear this person's story and fit that in with the multiple other storytellers that you have access to, and then describe that story. And the way you describe it with this approach is you rate the items. So as you're listening to people's stories, you're wondering, is this depression, or how are they doing at work? You know, because a lot of people now are laid off, right? So that's likely going to be a 3 unemployment, particularly if they're furloughed and they're planning on going back in 2 weeks. Well, maybe that's a 2. But if they're laid off and it's not even clear that that restaurant that they were working at is even going to be open in 2 months' time, then, well, maybe they're a 3, right? So you're listening to those stories, and the items then are the common themes, or the things that you need to know anyway. right? You need to know if you're going to help somebody. That's how you design the Texas ANSA and the Texas CANS is what are the common themes of the stories of adults with mental illness that we need to know if we're going to help them. So you're just listening to those stories, you're combining multiple stories, and then you're, of course, putting the action priorities and you're contextualizing it by interventions in place and culture, etc. So that's all it is. And so the key is when you're doing this in a phone environment is remembering that's what it is. So I don't recommend you actually get on the phone and say, now we have to do the CANS, how is your family functioning? You're not doing it that way. It's not an interview. You let people talk. And then you use, and so the best way to do this is understand what you need to understand. So you know the mental model of the ANSA, the CANS. And as you listen to stories, if there's things that are missing from that mental model, and so I would actually have the form sitting by you, by your phone or your computer, and start checking things off as you hear people talk about it. And then you can revisit it if you're not sure, is this a 2 or a 3 or something? You can ask for more information to help you clarify, is this a priority? Is this an action level? Is this something to keep an eye on? So that's a key thing to remember so that you don't let the tool interfere with your relationship with a person. You don't let it intrude upon your conversation, except to help you keep organized in your conversation to make sure you learn about this person's story, what you need to know to be effective in helping them. So I'm going to turn it over to April now to talk more about technical details of this kind of process. And if there's any questions, of course, we can entertain them, but I think we're better off if we leave those for the end. So it's all yours.
Thanks, John. All right. So I'm going to go back, take a step back for a minute, and then I'm going to go right back into link to what John has been talking about. So in my perspective, I think collaboration becomes way more important when we're using technology like phones and video conferencing to provide care to our clients, right? Collaboration, for example, is not just between professionals. It might include people who need to support our adult clients or the children or youth that we're working with when we're actually interacting with them from a distance, right? So collaboration becomes a really important key. So some things to keep in mind when we're in this new collaborative environment, those are the things I'm going to talk about right now. So some things to keep in mind before you even have a telehealth session, right, is to think about how are you going to structure this session, because it's going to be different than if you're sitting in your office or sitting at the clinic, right? And once you figure out that structure, you need to explain that to your client or to the child or to the youth or to the caregiver who you're working with so that they can think through what that's going to be like for them, this different structure that you might have. You need to think about the technology that's available to you as the clinician or the case manager, right? What is the technology that your organization is supporting you in providing? And how comfortable are you with that, right? And if you need support, what kind of support do you need with that? Then you have to have the same conversation with the people that you're going to be working with. Not everybody has a computer that's got a video camera. Most people have smartphones, but not everybody, right? Some folks get really anxious and nervous when they're starting to use the technology in a novel way. So using it for a session might be novel to them. So even though they're used to using their phones for Snapchatting or tweeting or texting, this might throw them off, so they might need some more support. Okay, and then talk about how you are going to use the technology. If you're going to video conference and you're going to do it through smartphones, you need to let them know that you're going to do that and that you would like them to be on video conference and what things they might do in order to keep the phone stable and who needs to be in the picture, et cetera, et cetera. So just some things to think about ahead of time, particularly if your clients need some support on the use of that technology. Right? When you're beginning the assessment process or the session, always check to make sure the technology is working. And if it's not working right, take some time to troubleshoot. So you might create some extra space in your session, whether that's a team meeting or in an individual session, for any technological glitches that could happen at the beginning, okay? When you're talking about your informed consent, when you're going through your informed consent process at the beginning of your treatment cycle, you might need to talk a little bit extra about privacy, right? And how to set up privacy at your client's residence, right? Think through with them, are you in a place where you can have privacy? Are you in a place where if it's a group of you, like it's a family that you're working with, is there a place in the house where it can be private and the dogs won't be jumping up on you? Although my cat jumps up on me all the time. When you're talking about informed consent, you might also talk about confidentiality and what things you might do to maintain confidentiality. All right, so there's some extra things you might need to talk about. The other thing you might need to talk about, since you're not in your clinic or in your office, you have policies and procedures that are already in place in case an emergency happens, in case someone gets distressed. But now that we're in a different situation, you might have to
April?
I'm going to text her right now and say we can't hear her.
Perfect, thank you. I know
a
there's
medical emergency that happens. These are the things you need to sort of talk through and get some help in thinking through with your client as to how
you were offline. Nobody heard you about 1 minute.
When technology fails, you will need to come up with a backup plan, right? Right now, if our internet connection shuts down, right, what are we going to do? Are we going to have a landline available? Are we going to have a cell phone number available? Is there another person in the house that you could call in case something happens to check in on your client? If that's a caregiver, an adult for a child, or it's another adult for an adult client, right?
Dr. Fernando.
And again, develop those strategies, signals, cues, verbal signals, visual signals and cues to let, so that the client can say to you, hey, this is too much, I don't want to talk anymore, or I'm getting overwhelmed, or I just need to go to the bathroom, whatever the case may be, to develop those signals ahead of time. All right, the other thing to remember is the Therapeutic Alliance is still really important when you're on phone and video conference. It's really easy when you're on the phone to just get down to business and not check in with someone, because that's what we do on the telephone, right? We sort of get to business. So you might need to slow yourself down to sort of check in on someone and see how they're doing before you get into business, right? Talk about the fact that you might get cut off. A call might drop, the internet signal might waver, and that if you get cut off, it's not because you've hung up on someone, right? So to make sure that folks won't feel rejected by technological glitches. Body language is a real issue on this two-dimensional platform, whether it's voice or it's video. Video is two-dimensional, so it's sometimes hard to see people's facial expressions. So it might be helpful to talk to your client about that. So you might say something like, some things are different when we talk on video than when we are in the same room with each other, right? Eye contact's a little bit different, for example. I'm gonna do my best to look into the camera so that you know I'm paying attention. However, if you don't feel like I'm paying attention, it's okay to let me know, right? So I can adjust the way that I'm looking at the camera so you know I'm paying attention, right? So something like that might be really helpful to make sure that you're maintaining that connection and the rapport over video or over the phone. You might also talk about people's comfort level at various times during your interaction with them. Some people really like the phone and really like video conference because it cuts out having to drive, take a bus, all those things. There's less stigma. They don't have to go anywhere and explain it to someone. But some people might get overwhelmed with the technology. So it's a good thing to check in with people on this. All right. So back to what John was talking about, the CANS and the ANSA. The CANS and the ANSA have been used in telehealth and in HIPAA-compliant video conferencing for a while, whether it's for screening or assessment or actual using them in team meetings or whatever. And because collaboration and consensus building are at the heart of our communimetric approach in our tools, right? We need to make sure that we maintain collaboration and fully develop that consensus building aspect of our work with our individual adult clients and with the kids and families that we're working with. So we have to take time to be deliberate about everything that we're doing, which is what John was talking about a few minutes ago. So just to follow up with what he was saying, right, when we are when we're assessing or even checking up on a CANS or an ANSA, we want to make sure people understand what the CANS and ANSA is, right? So it's surprising sometimes I'll be talking about the CANS and people will say, I don't even know what that is, right? I even forget to explain what the acronym is. So it's important people understand what the CANS is, why we keep bringing up, why the ANSA is important, what the participation of our clients really means, right? It's really about making sure that we understand their perspective on their story, and we're using the action levels to help us understand where it is that someone needs support, right? And what level of support they could need, and where are their strengths and how we might be able to access some of those strengths to help them. That's the whole point of it. So if you're on video conference, right, it might be good to create some visualizations that you can help your clients understand and remind them of the action levels. The more visuals, the easier it tends to be. Sometimes you need to prepare folks, particularly if you're having a team meeting. Right? How is the ANSA going to be used in a team meeting? How are the items going to be brought up and addressed in a team meeting? And if there are some sensitive areas, you might need to talk with your client about how those sensitive areas are going to be brought up. And again, this is where signals, visual or verbal cues, can be helpful to know when your client is uncomfortable, in distress, doesn't want to talk about something, or needs your support in talking about something. When we're listening to our client's story or the family's story, again, being deliberate about what we are hearing and what we are understanding can be very helpful in facilitating that consensus building process. So rather, as John said, rather than going down the list of items, it's much better to have them talk about what's going on and listen to their story, and then sometimes take a pause and say something like, it sounds like this is an area where you could use some help, right? That would be a 2. Or it seems like this is a priority area for some support. That might be a 3, right? Or it sounds like this is something that's been a real source of support for you. That could be a strength. That in sort of pausing and making those reflective comments, what you're doing is you're trying to build consensus. By them responding, yeah, that's actually a priority for me, you can then sort of say, okay, this sounds like this is something we need to address immediately, which is a 3 on your rating sheet, right? So it's important that we take the time to be deliberate and explain to our clients why we're taking the time to be deliberate, because it's not usually how we talk to people in person. We tend to use a lot more nonverbal cues in coming to consensus when we are together in the same room. There's going to be disagreements, right, on how we understand areas of need and what the strengths are. And so when we're in those spaces where we're not quite agreeing, it's really important that we take the time to understand the impact of a need on an individual and find areas where everyone can agree on so we can start to build consensus. So as it says on the slide here, you might say something like this: seems like you might not think this is a big deal, but your job coach just spoke about how this is impacting your attendance and your health. Can we talk about this a little bit further? Right? So we're acknowledging that there's disagreement, but we're also identifying that this is something that is impacting the individual, and we want to get a better sense of what's going on so that maybe we can find a way to come to consensus around what's happening. If possible, when there are differing perspectives, it's always nice to acknowledge the differing perspectives so that we can come back to it later and revisit it and see if we can come to closer with each other and come to consensus. So you might, if you're on video conference, do it on a flip chart so that you can bring that flip chart back in next time. Or you could do it on the screen, you could type it on the screen, or whiteboard it if you're on video conference, or just say out loud, right? You know, George, tell me what your perspective on this is again. I'm writing it down, and read back to what you've written regarding what he said, right? So, but it's important that people feel heard and that they know that you're taking their perspective seriously. All right. So when we're reviewing treatment plans, it's important to make sure that we give the individual client enough time to reflect on all aspects of that plan so that we can understand if it's working or not. If we're working with kids and families, we need to take time to listen to all of their perspectives as well, and make sure that people aren't talking over each other when we're doing that, okay? During this time of our public health crisis, it's not unusual for needs to pop up that weren't there before. And so we might need to take some time to ask about some of those things that might be happening currently because of the virus, and see how we might need to reorganize our treatment plans to address those needs that have arisen. Okay, and again, if you're using technology, it's really great if you can show the plan, especially if the ANSA and the CANS items have been integrated specifically into the plan. It's good to show those items, and if any shifts have happened, any changes have happened, it's good to visualize that, right? And as John reminded me last night, a really easy way to visualize that is to take your rating sheet and to pick a color for each of the rating, to draw a line for each of those ratings, and you flip the rating sheet to the side and you instantly have a graph. A very low-tech solution to what may seem like a high-tech problem. Okay, when we review the treatment plan and we're particularly using visuals, it can really facilitate consensus building. It can help us identify where our clients have progressed and where we need to actually celebrate their accomplishments, and also help us identify where the plan might be stuck and we need to find a different way to address those needs so that the plan can move forward, and the visuals can really help in that. So those are some of the tips that we pulled together. Happy to hear what some of your questions are.
Thank you, Dr. Fernando. Right now, we have one question that asks, when teleworking, we cannot encrypt everything. How do we handle this concern?
Desiree, were there any questions you wanted to bring up?
Oh, can you hear me?
So I think that that the federal government is. I don't think April can hear us, so I don't know why.
You
But
can hear me though, John?
I can hear you. Yes. Let me text April.
Okay.
But I think, as I understand it, the CMS has relaxed telehealth guidelines to make it HIPAA compliant regardless. So, I think
While we're waiting for that,
guidelines
John, was there
are-
anything you wanted to add to what I had to say?
Can you hear me, April? I don't think she can hear us.
Dr. Fernando, can you hear me? This is Mary. Oh, she can't hear me either.
All right. I know there was some questions that were sent beforehand about specific ratings too, but my understanding of the non-need for encryption, it's always better to encrypt, but I think there is some relaxed standards under the circumstances, so I would look into that and consult your privacy officer to make sure you're within compliance. Yeah,
Thank you,
so
Dr. Lyons.
she cannot hear. I don't know why.
Okay. I'm going to go to the next question. I sent her a chat as well. The next question is, do you have any suggestions or tips for kids who do not want to participate at all during the CANS assessment? Maybe ways to engage challenging kids.
Yeah, so I think that it's the same set of issues, but even more challenging, of course, in a tele environment. So there's a bunch of different strategies people in the collaborative have used around that. One is letting kids have more active control of the process, like pressing the buttons and so forth. So if you can put your rating form up on the screen and give them control over it and have them select the rating levels and so forth as you talk about, summarizing the story after you've heard it all, and you start to pull it together to make some sense of what's going on. Giving the kids more active control of that process is sometimes a way to engage. I think you have to kind of go with wherever that young person is, because different kids are activated by different things. So always the first step is to ask them why they don't want to participate, right? So that's probably the most common way of engaging kids, is to understand what the reason is they don't want to participate, so that you can begin to address that. So there might be issues. There could be any number of issues. So you might have to have, separate conversations sometimes. So in terms of building that engagement process, typically if you make stuff fun, kids are more engaged. And, frankly, sitting around and talking among adults is not something that most children or adolescents find particularly positive or entertaining. So being creative in that sense and doing something a bit more fun, more activity based, might be a better strategy. There's a bunch of games that people use, for instance, to or kind of game-like activities that people use to engage people in a way that doesn't sound like some sort of serious conversation about what did you do wrong now. So
I just want to let you guys know I'm back on.
thank you, April. So can you repeat that question, Desiree? And April might have a different take on it or additional takes on it.
Sure. So the question is, do you have any suggestions or tips for kids who don't want to participate at all during the CANS assessment? Maybe ways to engage challenging kids.
I do think well, it depends on if it's the first assessment or not, because you may not know the child very well. But I think when you prepare ahead of time to chunk up the conversation so that there's more, there's ways to engage them that are fun, and then there's times where they can go and do something else and you can talk to the parents. I think chunking up the conversation usually helps. And I always encourage clinicians to share a little bit about themselves so that and it's harder on the phone and on video conference to do this, but it's important for kids to feel comfortable with you and get to know you. So you might have to do something to help them understand who you are a little bit better. So sometimes I usually try to call the caregiver ahead of time and say, is there anything that they like? And then, you know, if they like cats, then I talk a little bit about my cat, you know, to sort of get them more comfortable with you as a human being, not that you're a person that's going to get them in trouble and highlight all the problems they're having.
Thank you, April. There was also a point during your presentation that you cut out for a little bit.
I'm sorry.
I know you can, that's okay. So it was during the part you were talking about when, what's the best practice when someone is having a crisis in this type of situation?
Yeah. So when someone, so I was talking about setting a safety plan, right? And just so people know what to do when there's a crisis. And that safety plan includes who is in the residence where the client is at, engaging them, which is part of the collaboration now we have to build in this, when we're doing telehealth. But it also has to do with knowing where the client is at. Let's say you're working with an individual client. It'd be good to have their address so that if something happens and they collapse or something, you can call and get emergency response out to their home. It also includes needing to know where the local hospitals and the numbers are so you can call. So it's kind of, I know it sounds scary, but these are the things we have in place when we're in our clinics and in our offices, and we have to think about these things now when we're providing telehealth when they're not in our office. Our clients are not in our offices and not in our clinics. And part of that is, again, preparing people. So with kids, it's easy to think about, oh, I need to prepare the adults that are involved with them, the caregivers, whether they're in residential care or they're in a home, in a foster home, or home with their parents or their guardians, right? It's harder sometimes to think about that with our adult clients. So we need to be a little bit more deliberate in thinking about how we're going to do that.
Thank you. The next question asks if you can show how to make that color-coded chart that you mentioned earlier, or elaborate on it.
Yeah, absolutely. So most of our, and I'll send you an example, Desiree, that you can get out to people. Most of our rating sheets have the item and then 0, 1, 2, 3 in either bubbles that you fill in or boxes that you check. So basically what you could do is say 0 is green, then you can fill in that box with green. If a 1 is yellow, then you fill in the 0 and the 1, you connect it together so it makes a line. And let's say a 2 is orange, then you just you fill out 3 boxes and connect them so that you have a line that's orange. And a 3 is red, then you do the same all the way. And then when you turn the sheet to its side, then you have a bar graph, basically, right? So I will send Desiree an example so that you can see what that looks like. I used to do this in my practice with little kids, and they filled it in as we were talking, and it gave them something to do. But they also started to realize, oh, these numbers and these colors mean something about me. And it was helpful for them to sort of see the changes over time as well. The other thing you could do is you could be really creative around this. I know Northwestern did a thumbs up, thumbs down type of visualization. I use emojis with kids, right? Pick an emoji for each of the action levels, and you know, that's helpful. So there's a lot of different ways you can do it.
Thank you. I'm not seeing any other questions at this time, but feel free, if there's other questions that you might have, to type them into the questions box that is available on your control panel.
Desiree, did you want us to talk about the 2 questions that were sent to you by email prior? We can mention those if that's helpful. How do you rate
Yeah,
sleep?
that would be great. There may,
Do you want to take those?
yeah,
How do you
that would
rate
be great.
sleep, and how do you rate employment in the COVID-19 environment?
I think you talked about the employment one already, John,
I think you're right.
in your comments. I think we should also talk about the school question that came up from New York.
Oh, yeah, good. Yeah.
So there was a question about sleep, right? So there was a question about someone who is sleeping a lot because they're depressed. They sleep about 10 to 12 hours a day, but they feel rested when they wake up. But their sleep is causing friction in their marriage and their other relationships. So the question was, how would you rate sleep? And so my answer was, clearly there's an impact of sleep because they said it's causing friction in the marriage and the relationship. So I start thinking it's causing, it's impacting function. I would start thinking a 2. It was hard for me to determine whether it was a 3 because I don't know the extent of the impact, right? I don't know what causing friction means.
Right.
Once I'm clearer on what causing friction means, I might be able to put it to a 3 or not, right? So if it's causing friction in the sense that, the marriage is about to end in divorce, then I might think that's a 3. If no friends want to, no more friends are around because the person sleeps all the time, then that's probably a 3. But without that understanding what causing friction means, it's hard to know if it's a 2 or a 3. It's definitely a 2 because it's causing impact on functioning.
Yeah, unless the friction is very mild, then it might be a 1, but yeah, it's typically going to be a 2.
Yeah.
Right.
Yeah.
So what we
You want to
landed
talk
on
about
with
the school one, Joe?
yeah, with school, what we landed on is attendance becomes, are you participating in a school activity? So if you have online school or you're being sent home homework or that kind of stuff, you're doing homeschooling or whatever, then the school attendance would be rated as the child participating in that process. So if you have a child who's home from school and is simply not doing any school, then that would be a 3 on attendance. They're not participating in school. And again, it's about the what, not about the why. That's, there's some schools that are simply totally unprepared for this, and so they don't really have any of those options. And so, but that they're not attending school, and that's a 3. Achievement, I think we decided where we landed is that you just leave it where it's been because it's really, really hard to know right under this particular environment. So you just rate achievement where they were when they were last before the school was transitioned to home. And behavior is how you're behaving in a home-based classroom environment. So if you're getting online and doing the activities and participating and behaving yourself, then that's a 0. But if you're causing your family all sorts of hassles because you're not able, willing to do that, and it becomes a major challenge for your parents to get you to focus on school and so forth, then that could be a 2 or a 3, depending on exactly how severe that behavior is. If you're tantruming, of course, because you don't want to do it, then that would more likely be a 3.
Thank you. The next question is, how are we gathering consent via phone, and what consents are we getting?
That's probably consents. That's probably more of a question for your legal folks than it is for us. Or consensus. I heard consensus first, and then I heard consent. So they sound sort of the same on the phone. Did you ask about consent?
Consent.
Consent. Yeah, I don't think that's our purview. I think there's ways of doing it on the phone, but that's not. I don't think that's my skill set. Do you know the answer to that, April, by any chance?
Yeah, I was just going to say that's a policy question that I would ask your organization to help you think through. So yeah, I agree with you, John. That's not our bailiwick.
We don't want to give you
So Desiree,
information that doesn't apply to your setting. That's the problem. So.
Yeah.
So this is Mary, and with HHSC. So more along the lines of consents, that is going to go back to the whole telemedicine, teletherapy policies and regulations about what is required and what you would do. So I do know that we will be having further information coming out about that, but you could always resort that back to your administrative code, your TAC rules, about how those consents are supposed to be done. And then of course, also looking to your agency, like what Dr. Lyons said about what your center says that should be done about gathering those consents.
Thanks, Mary. The next question asks, how do you recommend we assess an individual using the ANSA and cover all ANSA questions without it taking too much time and it going over the time of your scheduled appointment?
Yeah, I would say a couple of things that you have an opportunity here to break things up, right? So you don't necessarily have to do 50-minute hours if you're clever about how you do your scheduling, and that might actually work better with adults, depending on exactly what their symptoms and functioning issues might be. So think about chunking in a different way, because you don't really have the same kind of environment that requires that people show up, sit in the waiting room, and you're just doing a factory kind of people in a row. So you can do it differently if you're clever about that. I also wouldn't necessarily, and I think the most important thing though to remember is you don't have to ask a question to know the answer, right? So you can actually approach this as you're listening to people's stories. If they're saying something's not a problem, then it's not a problem, and you don't have to ask them specifically. If sleep didn't come up, you may ask about sleep if you want to, but you don't necessarily have to. If it didn't come up, if it's not a part of their story, then that's a zero and you move on. So you don't have to ask everything to say there's no evidence of it. So, and I think that's, you don't have to ask specifically about psychotic symptoms to know somebody's not psychotic, right? I mean, you're just listening to them. And so they're not psychotic. You don't have to ask about that. So that's where it's so important to remember this is not a structured interview. This is the organization of the information that you get from talking to people. So make it just like your work. Don't make it like a separate sort of thing that you're doing that has nothing to do with your work. This is your work. This is what you need to know if you're going to help this person. And so you just build it into your process so that it's consistent in that way.
Right. If I could add to that, I think it's important to remember that you all have been doing assessments for a long time and doing them well. And I think the thing that trips people up is they think that the ANSA is like every other tool that you have in mental health, where you have to go through everything and have it for it to be considered complete. But the ANSA really tracks your understanding of someone as your relationship develops. The difference, though, from completing an ANSA and getting to know someone versus getting to know someone through a dating site, for example, is that an ANSA usually comes with a referral, right? There's a referral that comes to you. You are a trained clinical person, and you have things that you look for as a trained clinical person. And your interaction with someone also brings up more questions for you that you feel like you need to answer. So between those three things, the referral, your clinical training, and the dynamic that happens between you and talking with your client, whether it's in person, on phone, on video conference, that's going to dictate how you're gathering your information and where you're going. And if that's all you use, and then you completed the ANSA afterwards, and you did consensus building along the way, then that's what you gathered. You'll probably be able to create a treatment plan and a diagnosis from that information, right? You're going to have some things that you didn't cover that you're going to either rate 0 for need or 3 for strength, right? But my guess is that those are probably going to be secondary things that you might want to catch up on later. But for your initial intake discussion, wasn't that important, right? So I want to reiterate what John said earlier. Don't let the tool dictate how you do your work. The tool is supposed to support and capture your work for you.
Thank you. The next question is, should COVID-19 be rated under natural disaster on the CANS?
That's an extremely good question, and I would say it's heading directly towards that. So I suspect the answer to that question very soon is yes. I know it in New York City, it absolutely is yes.
Right. So that question is about, remember that item, sorry. The item is about, is the person experienced a trauma? And I believe in Texas, for the mental health side, you're still rating 0, 1, 2, 3 on the trauma. Is that correct? I know you can't respond, but I'm assuming it is. If it really depends on the trauma. So that's why John said in New York, it's definitely somewhere a yes somehow. It's not a 0. It's a 1, 2, or 3. But it depends where you live, right? Whether it's a 1, 2, or 3.
Right.
The next question is about the CANS again, regarding Section 7 trauma. They are saying, I do not see any category of the 11 listed to identify trauma due to a car accident. Can you please clarify?
There's not every trauma is on the trauma list. Those are the ACEs, and the ACEs don't have that. I mean, you could have a situation where you had a medical trauma that the cause of the medical trauma was an automobile accident. So if you had an automobile accident and you end up breaking your back and you're in traction for 6 weeks, that would be a medical trauma. But just the car accident itself would be a different trauma that's not listed in the ACEs. That was not one of the ACEs, so it's not included in your trauma list.
Or it could be a man-made disaster, right? Depending, right? There was a pileup of 69 cars somewhere on the East Coast this last fall, right? That would be a man-made disaster. It could have been caused by fog, then it's a natural or man-made disaster.
There you go. So the answer is always it depends, right? So you have to really think of it contextually.
Okay, the next question asks if you could please repeat the information about employment. They missed that part, if you don't mind repeating that.
Sure. So typically, if you've got somebody who's lost their job, they've been laid off, it's going to be a 3, typically. Now, if they're furloughed, so in other words, their company says no one's going to work for the next month or whatever, but their job is there, and you're quite confident that they get their job back in that month, then that could be a 2. But if you've got a situation where, there's a restaurant that employed this person, they had to shut down, it's unclear whether they're going to even stay in business, it's unclear how this is going to last, I would rate the employment as a 3. So, but certainly if they're not working now because of the virus, that's going to be a 2 or a 3. If they're working from home, it could be a 0 or 1, right? So this is where the existing disparities in our system are going to be exacerbated because privilege matters in a pandemic. And so, like, I'm blessed because I can work and do my work at home. I'm sitting at home doing this conference call, but other folks aren't so lucky, right? They have either jobs that require them to be present for the job or they no longer have jobs. And that's a real challenge for folks. That'll be the longer lasting catastrophe from the pandemic for those of us who survive.
Thank you. I'm not seeing any other questions at this time.
All right. Well, thank you. Thank you all for what you do for others.
Oh, actually, there's one more, actually. It says, can you please clarify the rating on COVID-19?
You mean in terms of the medical? Is that on that item? I mean, it's a 0 unless you're infected, and when you're infected, it might just be a 1. But if you're infected with symptoms, then it could be a 2, and if you get pneumonia, that's a 3.
Right. So that would be the medical one. I think they're wondering in terms of natural disaster, if you're going to rate it natural disaster. That also depends on where you live.
Right. I would say most places in Texas, it's not yet. Although, as I understand it, Dallas is fast approaching something that could be considered a traumatic experience.
Right. Yeah, that they did ask specifically the impact of COVID-19.
Yeah, the impact of it. So chances are within the next 2 or 3 weeks, it will be pretty universally a natural disaster. So probably
I've got
it's going to
another
end up the
question.
single biggest natural disaster in the last century. Sadly. Go ahead, I'm sorry.
No, I'm sorry. If your client has not had any SI for over 1 year, do you still have to make a 1 on the rating?
No, not necessarily. If you're quite convinced it's historical and it's no longer relevant, so the 1 is history that's relevant. If it's totally irrelevant, get rid of it. Now, I would have a fairly high threshold for that. You know, I'd really want to be very, very clear that it's over and that it's not coming back, right? But there are circumstances, you know, particularly with younger folks or folks that were in a particular moment in their time and their journey that was particularly in jeopardy. And so it's all understood within that context. And now that's all been resolved and there's not going to be going back to it. So.
Thank you. I know we're approaching our 12 o'clock hour, and I know Dr. Fernando, you have another meeting to join. So what I would encourage people to do, if you have a question that comes up after we close the webinar, you're welcome to forward those questions to me, and I will connect you with Dr. Lyons and Dr. Fernando to address those. Again, all of this is being recorded, so we will be adding the link for the recording to our GoToWebinar channel, as well as we'll be emailing it out to anyone who registered for this webinar today. So thank you again for participating. April or John, did you have any last words that you wanted to share?
Well, I just want to thank everybody for staying safe. Thank you.
Yes, thank you very much.
Take care, everybody. Be safe.
Thank you. Bye-bye.
Bye.
Bye.